Thank you very much. It is really wonderful to be at this amazing global conference on our topic of the moment, care. And I'm really glad now to be chairing this roundtable on COVID-19 and care, because of course it is this recent pandemic that has made us all so aware of care and how much we need care, how much we depend on care, and how careless our whole world has been, how undervalued care has been. So we have many presenters. We have 9 people speaking today in 4 sessions. So I'm going to proceed at once to begin calling upon Daisy May Barker, who's a doctoral student at Lancaster University, and she will be discussing Mothering the Crisis, an exploration of the experiences of mothers working from home in the first national UK lockdown during this pandemic. So welcome, Daisy. I'm so glad you're here.
Thank you for your introduction. I'm just going to share some slides, but whilst I share my slides, I'm just going to turn my video off. All right, so yeah, I'm Daisy. I'm a first year sociology student at Lancaster University. And today I will be presenting a paper that's adapted from my master's dissertation. So just before I begin, I'd just like to give a quick trigger warning, just to say that I will be briefly discussing these potentially distressing topics today, and the warning symbol will be appearing at the top of this slide to alert you when I'm going to discuss them. So my master's dissertation research took place in the summer of 2020, and it aimed to both document and analyse the experiences of mothers who manage both productive and reproductive work whilst working from home during the first national lockdown in the UK. And I interviewed 6 middle-class mothers and analysed this data according to a social reproduction theory framework. So my paper today is based on a chapter that focused particularly on the reproductive labour. And for the purpose of today's talk, oh, sorry, didn't mean to do that. For the purpose of today's talk, I will be particularly focusing on the reproductive labour chapter, and I will introduce my theoretical and historical framework that I used in my dissertation, concisely by focusing particularly on why I chose to conceptualise their labour as reproductive instead of care. And for the majority of this paper, I want to focus on 3 forms of lockdown specific reproductive labour and responsibilities that my participants narrated in the words that they used as a really important political and methodological decision to use, their words to explain it, and then analyse some of this. So the framework of my dissertation took the form of a critical genealogy of mothering, labour and crisis, in which I considered how women's, particularly mothers, labour has historically been impacted by various different crises. So one example of this would be austerity. Social reproduction theory enabled me to do this analysis, and it's why I chose to adopt the terms productive and reproductive to describe the paid and unpaid labour that my participants were doing during lockdown. So this theory, social reproduction theory, has distinctly Marxist feminist origins and provided me with a labour lens to integratively, rather than dichotomously, analyse productive and reproductive labour and consider how this is gendered, classed, racialised and respectively valued or not valued. And probably most importantly, it enabled me to track how the political economy of social reproduction is reconfigured in periods of crisis. So as we can see from the slide here, Laszlo and Brenner's definition is particularly helpful, as it not only considers how this labour maintains daily life, but also importantly reproduces the next generation, and obviously can be done in both a paid and unpaid capacity. And obviously I was focusing on the unpaid in the home. So I'm very aware that this is a very brief snapshot of an incredibly nuanced theory, but a key argument I want to frame this paper with today is that the political economy of social reproduction, so that's the institutions across the state, market and third sector for such reproductive work done in schools or nurseries, collapsed during the COVID-19 lockdown due to either the closure or the limited capacities. And this collapsed into the household and disproportionately impacted women's labour and responsibilities. So the first form of reproductive labour that was predominantly completed by mothers working from home in lockdown in my study, and probably the first that comes to people's minds, was homeschooling. Particularly, I was interested in how the reconfiguration of both labour and responsibility for educating children, or essentially reproducing our future workforce, was shifted from either the state or the market to the household, and how this was experienced by my middle class participants. So I shall now read out these extracts. Each week, her school sent an intense homeschooling timetable. I probably managed to do an hour each day. I know it's not good enough. It should probably take more priority, depends on my workload. I worry that I am making her fall behind. And then another one. There are a lot of families who seem productively using lockdown to learn new skills and languages. I didn't want the pressure of this. So I think for me, these two extracts are particularly important for highlighting how the immense amounts of mental and manual labour involved in homeschooling alongside productive labour, particularly signal the exacerbation of a pre-existing pressure on middle-class mothers, particularly to engage their children in culturally and educationally enriching activities, both in and outside of the school, that was no longer possible. Whereas this is of huge disparity to low-income families who are likely to lack the time and skills and the access to, necessary resources to provide not only adequate homeschooling, but, this daily maintenance of life, which has resulted in the deepening of many, but including educational inequalities. So for me, it's both important and interesting to consider how this lockdown specific form of reproductive labour and responsibility is profoundly influenced by class. So as many of us have experienced, the crisis of the COVID-19 pandemic and subsequent lockdowns has had an inconceivable emotional toll. However, I think it's particularly vital, if not the most important aspect of this paper, to highlight how specifically women's emotional labour within the household has historically played a central role of absorbing the shock and the anxieties and the tensions caused by different crises. This was repeatedly evident across all my participants, who expressed various different ways in which they had to conceal their own emotions, their own traumatic times they were having, to reassure those around them, including, not only the partners, but their children. However, the incredibly moving extract I shall read out now provides one of my participants' very personal experiences of bereavement due to of a death due to COVID-19 in her family, and her consequent inability to perform emotional labour, which I shall now read out. I think as mums, it's our job to keep everything together and everything going in the home, but I just absolutely fell apart after the death of my nephew to COVID-19 in the first week of lockdown. I was so worried about my mum grieving for her grandson on her own too. I usually support her emotionally as a carer. My husband had to take over with our daughters and do a different side of my job as a mum that he's never noticed before, absorbing their worries. He has a new appreciation for some of the stuff us mums do behind the scene. So firstly, I think it's crucial to situate Joyce's experience within the necropolitics of the mishandling of the COVID-19 pandemic in the UK, in which she was emotionally burdened with the knowledge, which we talked about a lot in the interview, of how her nephew may still be alive if our country was put into lockdown 1 week earlier, as advised by scientists at this time. But also, I find it incredibly interesting to consider how through her husband taking on this responsibility of emotional labour during this period, it become visible and valorised by him. And this really, for me, amplifies the visibility of unpaid forms of reproductive labour that are completed in the privacy of the home until these moments of crisis. So above all, whilst emotional labour is by no means a new form of gendered labour that's predominantly completed by women in the privacy of the home or workplace or whatever, I think it's important to evidence how lockdown and the pandemic more generally exacerbated its conditions, as well as the labour and responsibility involved in such. So lastly, another form of specific reproductive labour specific to lockdown that my participants completed whilst working from home is another one of these invisible gendered forms of labour that would regularly be omitted in research, and this is something that I've termed lockdown management. So I adopted this term to specifically refer to the different ways in which the mothers I spoke to considered it their specific role to both manage and take responsibility for the threat that COVID-19 posed to their household, in which they adopted various different strategies throughout the different stages of lockdown. And, you know, within my historical analysis, we can see this as a long history of this management labour in the household that, you know, can be compared to, you know, make, do and mend throughout rationing in World War II, and echoes of this frugality in the household and its associated gendered, classed and moral discourses throughout austerity. So the two extracts I shall now read outline some of the specific tasks that managing lockdown in the household entails and the conflicted thoughts that my participants had about this. I used to make my husband take all of his clothes off at the door when he returned from work to minimise the risk. I was like the household supervisor. I also found about all of the medication we would need if any of us got the virus, because I knew I couldn't go into hospital unless it was serious. I would have to manage it. Now, I'm not going to read the next extract because I know I'm a bit short on time.
Yes,
but it's sort of sorry, Lynne, I'm finishing it up now. I'm wrapping it up.
That's good. Thank you. Thank you.
Yeah, so the next extract just directly brings that back to the blame and the hard decisions that the mums felt like they specifically had to make and were burdened with in this context. So I think it's important to situate this within a long history of women sort of acting as the intermediary between the hospital and the home, but you know, to bring it all back together and go back to my key points, I would situate that also within this collapse of the political economy of social reproduction that is disproportionately impacting women in very different ways and exacerbating already and exposing the many inequalities that they face. And this project is something that I built on my PhD project. So I'll leave that there.
Thank you so much, Daisy, for your account of how women have been mothering the crisis, indeed. And now we're going to go out to a more global perspective. And Esuna Dugarova, are you there? Esuna?
Yes, I'm coming live.
Welcome, welcome. And Esuna Dugarova she's a policy specialist at the United Nations Development Project. And so she has been addressing the crisis of care in this COVID-19 global pandemic, seeing what the policy responses have been. I look forward to that.
Thank you so much, Aline. So, colleagues, hello, everybody. It's morning in New York, and I guess it's afternoon in the UK. So, first of all, I just want to say thank you to the organizers for this extremely, I think, relevant and important topic and all the hard work behind the scenes. So, thank you so much. So, as Lynne mentioned, I'm going to present a global perspective on unpaid care work. So what I'm going to do, so I think maybe it's worth first just very briefly a few words about the state of affairs so that we're all on the same page. And like from a global perspective, no country as of now, I think it's not surprising, has achieved the equal distribution of unpaid care work. And we all know that women, including elderly as grandmothers, dedicate much more time, despite the fact that we all know the economic value of unpaid care work and progress in reducing that paid care work has been slow, but at the same time, to be a little bit more on the positive side, we also see that more men are involved in unpaid care work than ever before. So here I would like to share some of the findings from the overview of literature that I put it more like a positive and also negative aspects that we have seen during this pandemic period. So from the positive side, there are some patterns or like instances of more egalitarian care arrangements. I don't think it's yet a trend. I don't think it will be, but I think there are some positive practices that we see, and that what we have seen from the literature review is that the proportion of families who share the unpaid care work has increased, and partly because men who either lost their jobs or they work from home have increased their participation, but more so in the so-called indirect, non-routine, or some scholars say enjoyable tasks, right? So, and but at the same time, we also see, I think it's still like a continuation and the reinforcement of this negative trend where there is more retraditionalization of care work. And obviously, as I mentioned, women spend more time. And I think as Lise also alluded to, homeschooling is also actually become like an additional task, full-time also in some cases for women who already have their jobs and unpaid domestic duties. So, and also what literature review shows is that working mothers spend less time on paid jobs and still even more time on unpaid care work. So, and the main factors behind that is, I would say factors that can explain that. So that depends on the employment status of parents. So for instance, if fathers let's say, have work from home, they're more involved. And if women, for instance, are in essential jobs, they still do unpaid care work, but maybe a bit less so than previously. It also depends on workplace arrangements and the flexibility that parents have, and also the type of job performed by women in particular. So, and now I would like to share the findings of the global gender response tracker that has been co-created by UNDP and Young Women. And it was actually launched initially in September 2020, and we had updated it in March. And along with colleagues, I have been part of the core team who created the methodology and all this gender analysis of the global response. And I would like to bring your attention more to the care policies that have been implemented. But as we are in academic circle, I think it makes sense a little bit explain the methodology behind. So we adopted two approaches to gender analysis. So gender-specific policy measures are those that directly addressing women's needs, like violence against women's measures, but then we also use a gender mainstreaming to a broader spectrum of policy measures that are not necessarily gender specific, like social protection, labor market, and fiscal economic measures. And to those like broader universe of the socioeconomic measures, we apply two gender analytical questions asking whether they target prioritize women like cash transfers, and whether those female dominated sectors that have been hit among the hardest during the pandemic. And then based on these analytical questions, we came up with those policies that are gender sensitive. We frame it gender sensitive because they're far yet from gender responsive. So what the findings have shown, and I think it shouldn't come as a surprise, is that the global policy response to the pandemic has generally been blind to gender equality and women's needs. And that's always the case, I think, even not at peaceful times, but more so at times of crisis. I think women's needs always come at risk and always neglected. So in terms of the specific measures that address unpaid care work, it's 11% out of all socioeconomic, like social protection, labor market measures that have been addressing unpaid care work. And that is 180 measures in 81 countries. And most of these measures have been implemented in Europe and North America, which I also think not surprising because of like more mature labor markets and more resources that can kind of support this response. Now, there's a little bit more in detail in terms of what type of policy measures and in which countries. And we see that out of 81 countries, like 40, at least half of those countries, they strengthen family leave and paid sick leave. 34 countries supported the functioning of childcare services, and 11 countries provided a shorter flexible work arrangements. So based on this database, I selected some of the good practices in care response to COVID, and I intentionally focused on good practices in the Global South because I think we often tend to focus too on the Global North and assuming that if you have resources, you are more capable, have more capacity to introduce this gender responsive measures. But I think this good practices coming from the Global South actually do show that even despite relatively limited fiscal space, you can implement gender responsive measures even at times of the pandemic. So these are the case studies. I wouldn't go into detail, but just for instance, give you an example of countries like Trinidad and Tobago extended paid parental leave, countries like Peru scaled up home visits to support older persons and persons with disabilities, which is also responsibility of women to look after. And then countries like Chile provided cash for care to compensate working mothers, and specifically when childcare services were closed, and so on. So, and obviously I'm happy to share the presentation if needed. Now, I think the key question to ask is, we see that the global gender response, including to unpaid care work, has been blind, right, to gender equality. And we need to understand why has been that the case. And one of the factors that is contributing to that is I think, is women's underrepresentation in politics. Because we know from research that when women participate in politics, in decision-making, they prioritize issues such as education, health, childcare, pensions, and so on. So we can see that from another aspect of the global tracker, we analyze the women's participation leadership in national COVID task forces. So we have seen that women represent only 24% of members of task forces globally, and only 4% have a gender parity. And in fact, I think it's 27 task forces have no women at all, which I think is appalling. So, but there are also different task forces. So there are experts like advisories, and there are decision-making. This is really a decision-making task forces is about specifically political participation. And within decision-making, there are also different sectors like health, multi-sectoral, economic. And as you can see from this graph, that women participate even less in decision-making than as advisors. So to conclude, I'd like to provide some of the suggestions, policy recommendations that I think are important to ensure that unpaid care work is addressed. So one is national care system and labor market policies, which are interrelated. So on the one hand, I think it's critical to support working parents through paid leave, especially fathers' paid leave, and also ensure quality care services, not just care services, and obviously prioritize investment in social infrastructure. In terms of labor market policies, I think as we have seen, like female-dominated sectors have been affected, and a lot of women have lost jobs. So I think it's important when we talk about policies, it's not just about creation of jobs, but decent jobs, safe jobs, but also I think upgrading women's skills so that they can adapt to the new conditions of the 21st century, including digital skills. And obviously flexibility is critical. And we know from research that lack of flexibility at the workplace and lack of men's involvement in parenting are among key factors that make women quit the labor force. So, and obviously, last thing I just want to highlight, and I think something also Lisa mentioned earlier, is this importance of mental health, because over the pandemic, there has been a great toll on emotional well-being, and obviously women have been affected more so than men due to different multiple or workload and responsibilities they have. And it's very much still neglected in global discourse and practice. So I think this is a key part as we move forward. And obviously all this won't be possible if we don't have adequate funding to support care and labor market policy. On this note, I'd like to thank everybody for listening, and feel free to email me. Thank you.
Thank you, Esuna, for all that information. So much for us to digest. And now I'm afraid we have to move straight away because we have so many more people to hear from. And I'm turning to Amy Kipp and Roberta Hawkins, who are both from the Canadian University of Guelph. And they will talk to us about the complexities of caremongering in virtually organized community care in response to COVID-19. So welcome, Amy. Is Roberta there?
Yes, so I'm actually presenting on behalf of both of us today.
Oh, right. Okay. Welcome, Amy.
Great. Thank you. So good evening, good afternoon, and good morning to those joining from the side of the world I'm coming from today. I'm honored to be here talking about care with brilliant thinkers from across the world in a time when global conversations about care and the future of care are being centered, and as the COVID-19 pandemic and other crises are highlighting the many injustices created by uncaring societies. Within this international and interdisciplinary context, I want to take a moment to place myself and my research today. So I'm a PhD student at the University of Guelph. Sorry, I'm just sorting out my slides here, but I'm a PhD student studying social practice and transformational change at the University of Guelph. And I'm presenting on research conducted by myself and Dr. Roberta Hawkins, exploring the complexities of the caremongering movement. So the city of Guelph, where I live, is located on the ancestral lands of the Attawandaron people and the treaty lands of the Mississaugas of the Credit First Nation. Although the research I'm presenting today draws on feminist theories about care, I want to also acknowledge that care and interdependencies have been key to the way knowledge and justice have been practiced by First Nations and other Indigenous communities across so-called Canada for generations. In Canada, COVID-19 and the caremongering movement have emerged in the context of a history and ongoing legacy of colonialism, patriarchy, and neoliberal policies. These structures have created a situation in which care is frequently undervalued. During this past pandemic year, this has led to specific challenges for many Indigenous and racialized communities, as well as disproportionate rates of COVID-19 mortality amongst older adults living in public and private long-term care homes across the country. So with this context in mind, let me now answer the question that I hope many of you are wondering, which is, what is the caremongering movement? So caremongering is a community-based movement that began in Toronto, Canada, when community members looking to care for each other during the initial set of government restrictions created a mutual Facebook group that they called caremongering. The goal of this first group, as its name suggests, was to overcome growing discourses of fear or fear-mongering through community care, or caremongering. So in this virtual space, community members could ask for or offer support, share resources and information, and connect with their community. So for example, through caremongering, individuals have arranged to provide groceries for their neighbors, volunteer groups have mobilized to deliver meals to at-risk older adults, and nonprofit organizations have shared virtual mental health supports and emergency food bank access points, among many other forms of care. So the idea of caremongering has spread rapidly, and locally based caremongering Facebook groups emerged around Canada and internationally. Based on our analysis, which included a review of caremongering Facebook groups, the caremongering hashtag and its use on Twitter, and 25 interviews with caremongering organizers and group members, We identified 246 Facebook groups worldwide with over 300,000 individual members. Caremongering has been particularly prominent in Canada, with approximately 191 groups in nearly every province and territory. And caremongering has been described on social media and by journalists and politicians alike as a movement of kindness and has contributed to a national conversation on care. However, there have also been critiques of caremongering and what many see as a focus on uplifting stories and individual acts of care, which fail to hold governments responsible for the systemic inequalities highlighted by the pandemic. So in this way, caremongering provides a grounded example of care in practice during the pandemic, and as the CARE Collective describes in their compelling care manifesto, the ubiquitous complexities of care, including its paradoxes, ambivalences, and contradictions. So I want to spend the rest of my time today highlighting how such complexities showed up in caremongering by telling the story of one specific caremongering group in the province of Ontario. Informing the story is our analysis of 1 month of the group's Facebook activity and conversations with 3 group organizers and 5 group members. This group formed in the early days of the movement and grew to over 5,000 members. So in the first several weeks of this caremongering group, Facebook posts focused primarily on meeting the immediate needs of community members in response to the pandemic, such as sharing toilet paper or other limited goods, providing updates from local doctors, and offering to pick up groceries for those from local those who were afraid or unable to leave their homes. A few weeks after this group was created, organizers noticed a shift in the types of posts being shared as conversations began to focus more on structural issues such as systemic racism, unemployment, housing challenges, and the need for government supports. Describing this shift, Caitlin, one of the organizers I spoke with, told me that the posts very quickly became more urgent around marginalized folks and poverty, mainly folks that didn't have supports to easily deal with the challenges that this was bringing to them. Troublingly, such posts often led to comments on the group's public message board that perpetuated prejudice narratives about race and class among other identities. So for example, on posts about a local rent strike in solidarity with those unable to afford rent because of job losses, there were many opposing comments from more privileged members of the community, such as local landlords. Caremongering organizers used several strategies to manage such interactions with the goal of creating a caring virtual space. They began pre-approving all posts before they appeared publicly and developed a more comprehensive set of guidelines. And to support group moderation, they invited Chris, a community activist skilled in mediation, to join the organizing team. So Chris identifies as a Black man with lived experience of mental health challenges and poverty, and after joining the group, played an active role in moderating posts related explicitly to issues of social justice. So Chris described the complexity often involved in this role, saying that when someone has made a problematic comment, the thing is, we would have to decide, is this an explicitly problematic comment or intentionally incendiary? Is this based in ignorance or a misunderstanding of the situation? With something that is intentionally harmful, often that would be a deletion of a comment and the removal of the person from the group. Because if you're willing to be intentionally harmful, that's mongering of fear. He also worried that posts from some group members and even other organizers often minimize the reality of those directly affected by the pandemic. For example, he was concerned that many saw caremongering simply as random acts of kindness and that this undermined the political potential of caremongering. He told me about this, saying, we need to be wary of how caremongering functions and this kind of idea of just light, hope, laughter, and love, and not the heavy work, right? Because one of the things we ran into a lot was almost people deciding who to care about. It was like, oh, here's this post about folks who are systemically experiencing this hardship because of their marginalizations. And then we would have somebody comment that this is not the place for politics. This isn't related to caremongering. And we're having to explain to these people that this is directly caremongering. We also found that organizing and endeavoring to maintain a caring virtual space through caremongering involved a lot of work. So 2 of the organizers described the group in the way as a full-time job and told me that they were losing sleep because of their anxiety related to the group. They viewed caremongering as emotional and exhausting. However, they also spoke about it as rewarding and a process through which their own understandings of community care were being transformed. So for example, Sarah, who identified as a relatively affluent white woman, reflected on the way she had previously cared for her community, saying, the emotional work that went into caremongering was not what I had expected to get into. Someone like me who claims to be a community builder and claims to do good for the community, I've never been in the trenches like this, and I found out that I had not been doing the hard work of care, I was doing the nice work, and I was being caring, I wasn't being a caremonger. In her view, being a caremonger meant being willing to do the hard work of community care, such as having uncomfortable conversations, challenging structural issues, and acknowledging her own privileged position. She explained that doing the hard work could help facilitate deeper understandings and practices of care in her community. Or as she put it, you can't help on the surface level and then not look at what's below the surface. I think if you had bread and I had milk and we were able to trade, that's great. But caremongering went deeper than bread and milk. The value of caremongering is a conversation of what it takes to get that bread on your table versus mine. So through these brief glimpses into one caremongering group, I hope that a broader picture of the complexities inherent within this virtually organized community care is beginning to emerge. Our findings from this case study, as well as our broader analysis, emphasize the need for a nuanced understanding of care and the complexities inherent within it, while simultaneously centering care and community responses to the pandemic. Caremongering illustrates the complexity of fostering community solidarities in general, but also during a pandemic and through a virtual platform. For example, while caremongering provided a space for diverse community members to safely gather in terms of the virus, this space wasn't experienced as safe for all members. The virtual format of caremongering can help create and maintain relationships during a time of physical distancing, but it also created challenges for the relational engagement needed for communities to care with one another. Caremongering also highlighted the potential for virtual spaces to contribute to reworking collective understandings of who is responsible for care and how it is practiced and valued within communities. By creating a space where the care needs of diverse groups could be made visible and in some cases addressed, where individual and community privilege could be acknowledged and challenged, and where different types of care, such as care for, care about, and care with others could be simultaneously practiced. However, in some cases, existing understandings of care, such as what constitutes care and who deserves care, were reinforced. Careful and critical facilitation, as well as sustained participation within caremongering groups, was needed to navigate this complexity. Additionally, although virtually mediated, we found that caremongering had material and embodied consequences that were influenced by individual subjectivities and existing structures of power. So to navigate caremongering and the emotional labor it involves, we suggest that members take an intersectional, reflexive, and relational approach committed to addressing the underlying inequalities within communities and promoting collective actions aimed towards making structural change. We also acknowledge the limitations of community care when relying on free labor of community members within the context of limited resources and social infrastructure. And finally, I think caremongering illustrates that practicing community care virtually is not at all easy or straightforward. And it's not just about caring for the physical needs of others or sharing positive experiences. It is a relational, political, and an embodied practice. In this way, the work of virtual community care is complex work and it is hard work, but we suggest, as did organizers from caremongering groups across Canada, that it can also be joyful and hopeful as it contributes to building and reimagining more caring societies. So with that, thank you again for inviting me to share about caremongering, and I'm looking forward to the discussion to come. Thank you.
Thank you so much, Amy. A movement of kindness. How wonderful. Just what we need. But now I turn at once to three speakers, Pablo, Laura, and Anna. Can you all come onto the screen, please? Are you all here? I know one of you is not.
Lynn, I don't think the co-presenters can be here either, so we're actually fine to move on to the next presentation.
Oh, I see. Oh, that's a pity, isn't it? Okay, right, thanks very much. We're now going to move to Eana Meng and Johannes Lenhard from Cambridge at the moment, studying at Cambridge, who will be talking to us about care trade-offs, deservingness between drug users, public health, and COVID-19. Or is it just you here, Eana?
Yes, I'm presenting.
Oh, Johannes,
Johannes is here as well.
Good, both of you. I'm pleased to welcome you.
Thank you so much. Well, first of all, we are so grateful to be here. I am coming from San Francisco and Johannes is back in England. And we are very excited to be among a community of scholars and thinking about this really important question of something that we are continuing to go through. So without further ado, I'm actually going to stop my video as well because my Wi-Fi might be a little bit. As Lynn said, our title is Care Trade-offs, Deservingness Between Drug Users, Public Health, and COVID-19. And this is a presentation between me and I did this work with my mentor, Dr. Johannes Lenhard. And we did this work through Cambridge, as well as this organization that Dr. Lenhard founded called Cambridge Homelessness Impact Research Network. Okay, so a little background first. So back in March of 2020, all people experiencing homelessness in the UK were supposed to be offered accommodation by local councils in March, but then that was extended to June. And compared to other European countries, this response to the pandemic was more generous than expected, as there are obviously constant budget concerns. And this was a very surprising offer. Over 14,000 people were housed following the restrictions in March, and the government also announced an additional $433 million pound plan to ensure 5,000 new long-term housing units. So one of the central question we were asking was, did that work? What does it mean for that to work, and exactly who did that serve? And our summary is that while many homeless institutions were able to shoulder the increased burden of care during COVID-19 and the lockdown, some of the most marginalized people were not supported and fell through the safety net. And so we conducted our research in Cambridge, in a homeless institution there, from March to July 2020. We did this with participant observations. Dr. Lenhard was actually there and was able to visit. And so our key takeaways are three, and I'll go into detail about each three of them. But first is this idea that unconditional housing does work, and I'll get into what housing first principles are next. And the institutions were able to provide housing for many people and also provide for their daily needs. So that's certainly one positive thing. And then our second finding was that some of the most marginalized people fell through, even if temporarily. So people with mental health and struggling with addiction not only struggled the most with lockdown restrictions, but they were also penalized for it. And then our third takeaway was this shift to digital care was rocky. I think it was rocky for many, many people, but it was especially rocky in institutions which are contingent on that face-to-face care and that sense of community and camaraderie. So first, housing principle is, if people are not familiar with it, it was something developed out of the United States. And the idea is quite simple. The first principle essentially is that, or the first tenet of it is that the most effective solution to homelessness is permanent housing. And the second part to it is that all housing to those experiencing homelessness should be provided as quickly as possible, unconditionally, which means that there aren't preconditions such as sobriety or that they had to have been homeless for a couple years or anything. It's just absolute unconditional housing. And so we found that these housing first principles and unconditionality were met with strong engagement. The process of assessing candidates for emergency accommodation, including the rented hotel rooms many people were still in, was drastically shortened and sped up without too many apparent downsides. And secondly, despite the administrative effort to secure enough short-term housing, as well as concrete details such as food provision and security, many people took up the housing offers. As social workers put it frequently, many more people were able to be engaged than ever before. The unconditional offer of housing was a long-awaited invitation that many entrenched rough sleepers or people experiencing homelessness were waiting for. And thirdly, the assurance to continue the provision of housing for people until a suitable long-term option was found to make the offer even more successful. And so some of the intended consequences of that were there was a provision of emergency housing for a large number of people experiencing homelessness, and as I mentioned, strong engagement and support now and going forward. Some unintended consequences, both positive and negative. Positive is that this is certainly an opportunity to end homelessness. But the negative was that there's punitive surveillance for those who disobeyed in favor of the majority, which we'll get into in the third slide. Okay. And now, unfortunately, we found that some of the most marginalized people fell through the safety net. And so there's a lot of specialized support services. So as you can see on the left side, there's this widely distributed system of care, and that speaks more to how the system is set up within Cambridge, where people can access addiction support in one area, GP and access surgery in another, there's a day center, and then there's all sorts of different types of housing and outreach. And so it's really quite specialized and dispersed in a bit. And so the person experiencing homelessness really had to navigate that as well. And so when COVID-19 hit, the specialized support services were suspended or moved online. And those, especially suffering from mental health conditions, were impacted. And they also, with drugs harder to come by and no money from begging practices due to inability to go outside, we spoke with and learned of a number of residents who disobeyed quarantine orders in order to obtain drugs, often in fear of experiencing withdrawal symptoms, which is an incredibly hard thing to go through. And so lockdown not only created a disruption of normal routines, but it also quasi-criminalized them, either by government-imposed or institutional lockdown rules. So as a result, because some residents were unable to stay locked down and had to go outside to get money, to get drugs, some of these residents were asked to leave the support institutions as a means of protecting the other people, as a means of protecting the majority and the other people within the institutions. But that meant that there was nowhere left but the street for these people who were most marginalized. And so one of the questions we kept thinking about is how can we avoid such a trade-off going forward? And then thirdly, as I mentioned, the transition to digital services was rocky at best. Previously, before the COVID-19, the person experiencing homelessness worked very closely with a support worker. The care was in person, it was one-on-one, it was regular, and it was based on trust. And then after COVID-19 hit, it was transitioned to either phone or Zoom support, and both those experiencing homelessness as well as the service providers that we spoke with indicated that there was a serious lack of engagement. It was very hard to build rapport. There's constantly people missing appointments, checking out completely. And also some of these institutions had group calls in order to have, prior to the pandemic, it was a place for people to come together to speak, make friends, and in general, just foster a sense of camaraderie and community. But over Zoom, that was very difficult to foster. And yeah, many people would have their videos off or muted. And as we all know, that is very hard to connect with others through that platform. And so those were our findings of this time. And to go back to our conclusion and key takeaways, it was, while the provision of care from the UK government was surprising, it certainly had many issues. And one question we wanted to emphasize was that sometimes things that seem really great, right, this offer that so many people were waiting for, both support institutions as well as those experiencing homelessness themselves were waiting for this opportunity. It wasn't well thought of enough so that the people that were most marginalized and needed most help and most care were actually the ones that were most criminalized, even more so than they were prior to the pandemic. And so we leave you guys with that question, and we're excited for the discussion to follow.
Thank you so much, Eana.
Thank you.
And so that's the end of your presentation? Yeah?
Yes.
Yes, good, that's good. Well, thank you so much. Clearly, then, we really have a lot to discuss, and where to begin. That's been the problem we've had throughout this conference, when there's so many issues coming up all the time. So all the papers we've just heard in this session illustrate how much this pandemic has increased the amount of care that is needed. So we began with Daisy showing us that in particular, and unsurprisingly, it's women and in particular mothers who've borne the heaviest burden of care, even though fathers do end up doing just a little more domestic work, particularly when they find themselves at home, which was something which Esuna also found globally. And yet, as Esuna's research showed, this gendered dynamic, although so very clear, is still being barely addressed in global policy responses. So, our question we need to discuss now is, how can the rest of us react to this to try and make sure that this gendered dynamic is addressed, but also, how can we make those burdens of care fall less on any one person or persons? So obviously, for instance, one might think of the political work of the global women's strike, which has been so important every Women's Day, and trying to emphasize, how much everything we do relies on care. There is no life without care, and yet somehow care is always pushed to the background. So we get calls from many different countries, I think now, for universal basic care, for shorter paid working time, for father's leave, as came up in the discussion, and just for more spaces for caring. And I liked Amy and Roberta, who wasn't here, but so Amy's notion of care mongering, which seems to relate to what we in the UK here have seen as building practices of mutual aid and solidarity, because interestingly, as you mentioned too, mongering has always tended to have negative connotations, which it shouldn't really, should it? Because it's about work, fishmongers or people who actually do the work of providing things. So it's interesting that it has tended to go with fear-mongering or war-mongering rather than, the movements of kindness, which you talk about, which now hopefully is spreading both within Canada and perhaps elsewhere, with quite a differing affect and a differing intent to signify the centrality of how we care, how we look after each other. And that, of course, brings up the whole question of the language of care, the meanings of care, as well as the practices of care, which I think our Argentinian presenters, if they'd been here, were wanting to present. They wanted to talk, I think, about the mixed meanings and emotions of caregivers and care receivers. And of course, what we all know, that in different situations, whether paid for, it's underpaid, whether in the home, it's not paid at all, but always it tends to be marginalized and undervalued. So our question is, can we begin to turn that around, which is, of course, why we wrote our care manifesto as well, to demand that care be placed at the very center of politics, but also that it be democratized, that it be degendered, also deracialized, because we also know with the movements of care chains around the world, those who are doing the underpaid work of caring tend overwhelmingly to be Black or ethnic minority women. But also the question of how you democratize care in particular relates to the issues that were raised by Eana and Johannes when they raised the question, who deserves care, and point out that there are certain groups of people, those already marginalized, those already undervalued, who are going to always find it hardest of all to access care, who are going to fall through our caring networks or be pushed out of them, drug users being a clear example under COVID-19. So how can we avoid this? Well, I mean, I think the first thing is to try to return to what was meant to be that post-45, post-war consensus that everybody deserves care, and everybody deserves care from cradle to grave. Nowadays, only the rich are really getting care from cradle to grave. Other people are not getting it, but to greater and lesser degrees, because the whole notion of everyone actually being deserving of care is something that has been pushed so to the side over the last 4 decades with the cutbacks in welfare and the contempt for anyone not able to stand on their own 2 feet and be independent. So yes, the language of care has to begin from saying, actually, we all depend on care, not just those drug users and not just the elderly. Throughout our lives, we're actually making use of all our infrastructures of care. And yet, you know, we've been allowing them to be run down. Here in Britain, massive shortages of doctors, massive shortages of nurses, precisely because the conditions are so bad. The pay is inadequate for people to be able to live anywhere near they have to work and so on. So that's the consensus we have to rebuild, that we all need care and we all deserve care, but also that we're all capable of practicing care once we actually develop a new communities and ideas that caring is important, which I think is what Amy in Canada is talking about in that caremongering. We need a lot more caremongering, or we need a lot more mutual aid. We need a lot more solidarity, as I would see it, and to realize then that you know, the point of life is about care. That is what it's about. The other things are all really to enable us to live well, care for each other. And of course, in this panel, we didn't say much about caring for the world and caring for the environment, but you know, we're not going to be able to live well and care for each other unless we all also have supportive communities in healthy environments. So that's the sort of thing I hope that we can all come back to when we discuss at this roundtable now. What comments do you have to what I've said?
Maybe I don't know whether it's like we can just jump in, and I think there are some comments, questions. But thank you, Lynne, for your very thoughtful, very rich comments. I think it's kind of a presentation in its own right. So thank you for sharing your knowledge and your wisdom. You know, you raised some of these most critical and difficult questions, to be honest, because there are so many debates, so many movements, and this care manifesto that have been promoting the importance of unpaid care work. And what we still see is that we have not moved the needle, to be honest. You know, it's still, and partly I think it's Sarah Cantillon in one of her presentations said that one of the reasons for that is that unpaid care work is still seen as a private domain, and it's still, and as a result is a responsibility of women. So I think there is kind of the tension in terms of like public and private, and I think we need to position and frame unpaid care work as a public policy issue. But how we can do it, and I think the research has also shown there are like several factors that contribute to that. And the important one is obviously political will, and more so left-wing governments, obviously. Another one is the feminist movement and the social organization, and also presence of women, as I mentioned in my presentation, women in politics. But it's not just about women, it's also feminists, right? So it's more like femocrats, feminist bureaucrats that can lobby within the government, even though they have a lot of difficulties, a lot of backlash, a lot of bullying, especially now in the age of social media. There's no protection and no instruments to address this. So I think, I mean, and so this is like one part. Another one, I think, and it's very much, I think, focused on like women's side, but I think we need to work more, and there are some also increasing work being done on transforming masculinities. and the whole concept of what it means and how it's been changed. And let's face it, men struggle as well, right? So, and there are a lot of questioning about their own positioning, their own status, their own role within families and outside. So I think it's kind of a very complex issue. And maybe yes, so these are my, I would say, immediate reaction.
Yes, thank you, Esuna. I think that is absolutely right, because this notion of the self-supporting, self-caring person who doesn't need any outside help, least of all from the state, does tie in with the notion, the traditional notion of masculinity, except that now we're all meant to be like that. We're all meant to be totally self-supporting. But I wonder, Daisy, if you think that those men's experiences in the home, having to help in the home more, do you think it's going to make any difference to how men feel about the work of caring and domesticity and so on?
Yeah, so in my research, obviously I focused on the mums, but obviously did hear a lot of stuff about the dads through what the mums sort of said and what they did, what work they did and didn't take on. And I think it was really interesting, specifically through Joyce's extract that I read out in my presentation, you know, sort of talking about how almost, even though that emotional labour had been happening in their household with their children for, you know, they were older children as well, so for 15, 16 years, he'd never really noticed it or never really thought about its value until that moment of crisis where he had to deliver it, and he realised what, you know, really important and really, you know, exhausting labour it was. But then I had completely different experiences where I had one particular participant called Amy, and she was, I would say, more upper middle class of my participants, and her husband had moved away to work but had to come back to the home during lockdown, and they were both working from home at the same time. And she was sort of saying how, you know, nothing changed. It was sort of as if, you know, he was usually away, so he didn't really know how to integrate himself back into the family, and he didn't really, he took on parts of, you know, the reproductive labour in the home, but not as much as she thought he would. So yeah, I think it's obviously very household specific, and I think really profoundly influenced by class. We know this from statistics that working class men are more likely to get involved in reproductive caring roles than middle class men, in some cases, but then in other cases that's completely different. So yeah, I think we're seeing, you know, it's a really important moment really in both the gendering and the ungendering of this reproductive labour. And we're at a pivotal moment in which we really need to map out of where it can and should go. And if not, we're at, you know, also a really pivotal moment where a lot of those things are, you know, gender inequality is, you know, at an unbelievable rate, really backpedaling. So yeah, I think we can pursue this as a really hopeful moment, potentially for men taking more of this labour on the home. But at the same time, if we don't grasp it now, I'm a bit worried as to what would happen.
I'm worried. If you think about, for instance, HIV/AIDS and how the gay community did seem to be completely transformed in caring for each other, and then they get a drug or something, cocktail of drugs, and a lot of it seems to get forgotten. But I guess it's a question of pushing it more into the trade unions, which, you know, have always tried to fight for shorter working time and so on. Shorter working time isn't for men to spend more time in the pub, it's to do more work in the home, isn't it? So keeping that to the fore. So your movement of kindness, presumably that's what you will be talking about, you hope to be spreading in Canada. What do we do with our time and what's it for?
For sure. I mean, something that is coming up for me is the idea of this moment, and there's like the specific moment in that we can rethink. There's an opportunity to rethink care in so many ways, and specifically in the caremongering movement, as these conversations are being made so visible in the many different Facebook groups across Canada, as well as in media and on social media, when these conversations about care and caremongering are really coming to the forefront. Like how do we go beyond just these conversations? Like, what are the next steps, and how can communities actually become more caring? And I think a key part of that is connecting to like the structural issues that have resulted in this moment, and the need for caremongering. So thinking as caremongering as a response to fear mongering, well, like what were the fears that so many people were experiencing in the early days of the pandemic, and why do those fears exist? So thinking of like the fears of isolation, the fear of falling through cracks in the system, and how community members were trying to fill that gap. But how can caremongering be more than just filling the gap? So like, how can we create caring communities that are also resourced and have like the structural, I guess the resources to actually carry this to the next level, to be sustained more broadly.
We know that those who regularly fall through the gaps are those with issues of addiction, or issues of so-called mental illness and so on, and so, but they have something to say, don't they? So I'm wondering, it's not just a question of providing for those with addiction problems or those with mental illness, they listening to them as well. Do you think that can come into practices, changing our practices of rebuilding the networks to include everyone, including those who tended to fall through? What do you think, Eana and Johannes?
Yeah, perhaps a sentence from my side. I was just last week actually at a co-production meeting that is organized and run by local councils, where people with lived experience of homelessness come together with people in the service provision sector. And a lot of the decisions that are taken at the moment on the local government level and the service provision level are run through that group beforehand, so that there's almost a kind of consulting process happening, where I think first steps are being made to include people's opinion into how care provision, and this is obviously professional care that's provided, benefit them and their needs. And I wanted to say one more thing, which I found very important to pick up from what you said originally in your comments, Lynne, about this idea that everyone is supposedly independent and we can't be cared for anymore, right? And that is a particularly big issue in the homelessness sector, and I say sector very deliberately, because the housing provision here is always geared towards an end, a finite point where people are exiting the housing sector again and can be independent, right? And a group that I think had been traded off in COVID, and that's been pushed through again through these cycles of being housed and then falling through again, they won't be independent, and we just won't accept that as society, right? There is some people who need help and who need care, and who often need professional care in various different ways, from mental health to addiction to other kinds of care. And I think there's tension between this idea of the entrepreneur, right, which is kind of the absolute end point of that. Everyone is now supposed to be an entrepreneur, be it a gig worker or just somebody at home earning some money via Etsy, selling things. That stops at one point. And I think we have a very, and we means both the policymakers and the government, but also us as society have a hard time accepting that there is people for whom that doesn't work and that need our solidarity.
Yes, although I would say, we all have a need to care, and caring jobs tend to actually be the most enriching of jobs, not the bullshit jobs that David Graeber talked about. And so I've been reading about research going on about care hubs in Dundee and other places where there were attempts to, particularly to appeal to, to draw into these care hubs those who were being most marginalized and left out, and, through theatre, through other things, that, caring is a reciprocal process. And even those who we might say most need care, it's not impossible for them to actually be giving something back and engaging and, talking about who they are, how they got to be where they are. And, they have life lessons to give us as well. So I wonder, Eana, do you have any thoughts on that? This notion of caring hubs where, there is more reciprocity than we like to think.
Yes, absolutely. And I actually wanted to tie to a question that Hannah Lucy, I think, just asked, where she says, I'm just wondering, did you see any evidence of people experiencing homelessness being partners in public health guidance rather than just beneficiaries of perhaps surprising decisions? So the work that Johannes and I have been doing at Cambridge with what we're calling the Cambridge Homelessness Impact and Research Network is to make sure that people experiencing homelessness are absolutely an equal partner in the research, in both the research, and we call them research push and research pull, where one side is a group of people asking for research from academics for, we need some more evidence on this. And the other side is the people providing the research. And we see it so integral to this process that people that are part of access surgery, that are part of the homeless institutions, whether as service providers or as themselves being people experiencing homelessness, feel that they are equal partners in this, essentially exactly what Johannes said, this co-production of knowledge and research. And in some ways, the evidence that we see does not need to be writ large. The evidence we see is where the people we spoke with, when lockdown restrictions were put into place, the sense of agency that was removed from so many is crucial to people who already feel that they have very little agency and control, whether if it's by product of their addiction or mental health or homelessness. It is incredibly crucial to be empowering people and to make sure that at the very least that they feel like they have agency in the decisions that are being made. And there absolutely is reciprocity in what we learn, right, as researchers from people. And I think moving forward, there should be certainly this leveling of hierarchies of who produces knowledge and who researches the knowledge. I think there's inherently to that can be a care process.
I think so. I'm just going to turn to some of the things in the chat now. There's a question about generational differences and how, well, we've been positioned in opposition to each other. Indeed, generational warfare. I think there's even a generational war game in the States. And that also is about the actualities of reciprocity, that even when we're caring sometimes for those most in need, suddenly if that person were to die or something, it is a great loss. It's not the case that one person is just giving and the other person is just receiving. And I think that has everything to do with valuing generational communications and so on. But do any of you have thoughts on that? You see that question there about children and the elderly and so on.
I think I'd like to speak to that and sort of make a comment about how I think at the start of the pandemic, we were sort of told this sort of story about how, we all had to, isolate and be in lockdown because, we had to, it was all about vulnerable people. They were the only people that were going to get the virus, the only people that were going to die from the virus, which we know now was a lie. And I think for me, it just highlights how the COVID crisis essentially is a crisis of responsibility in which the state and the government have completely abdicated their responsibility for social reproduction, for care, and have made these sort of tales to sort of fit that. But yeah, what you were sort of saying then, Lynne, was about how really we need to realize our vulnerabilities, our shared collective vulnerabilities and interdependence, and that's when they're making out as if that's the problem, where really that's the solution. That's how we move forward from this, and the collective vulnerabilities and independence and solidarities amongst intergenerations, I think. So yeah, I just wanted to highlight that point.
I think that's right. But of course, we face this horrible situation where what we'd like to see where communities could try to be building up these care hubs and other resources, and so people would get respite leave for care and so on. Of course, we've got exactly the opposite with the outsourcing of care, which is still, behind the closed doors of COVID. We've seen even more outsourcing, and that is quite terrifying, isn't it? I mean, I don't know if the UN can do anything about that, the poor old UN. I mean, how do we stop the market moving into, every aspect of care when we find our present cabinet in Britain sort of trying to hive it off to their next door neighbour or someone else to make profit from, rather than, to see this is really the sort of work, if we lived in a good society with our movements of kindness, that we would all be wanting to do, but instead we get the opposite. We get massive exploitation of those now doing the work of caring.
Thank you. And some of the comments made, and maybe perhaps allude to like the question, not directly, but something potentially relevant. So, I mean, just to also make clear, I speak in my personal capacity, so don't take my views as a statement of the UN. So I think what we see is that we live in the paradigm of patriarchal capitalism, right? And if we look at the really broader perspective, we kind of advocate for the paradigm shift. But to be honest, we have advocated it for ages also, and not much has happened at the global level. But at the same time, what we do now at the UN and UNDP specifically, we actually make a case for a new social contract, right? Where we put well-being at the heart of the agenda. But it's so political, all these decisions, because the UN and UNDP specifically is there to support governments based on their demands. So, and if I may say, it's not an easy conversation. But having said this, I want to bring attention to another issue that I think we focus a lot on politics and economy, but I think, and you, Lynne, as an expert, I think also given, I understand your background, I think we neglect the psychological side, because we talk about care, we talk about supporting each other, but a lot of decision making that is made is driven by our ego. And I think we have seen that response in some countries, that if those people in power have had a little bit less ego and a little bit more care for people and pursued not their own interests, but more public interests, I think the results have been different as well.
No, they did get rid of Trump, and but we have Boris Johnson here. But the real problem, I think, is it is a question of resources, which makes it a question of politics, but as well as also a question of ideology, I suppose. What do we value? And I do think that's where it does link up with green politics, doesn't it? And not plundering the world around us, and not thinking that we're here on earth for a few people to make massive profit. I mean,
there's something else I wanted to mention, based on this question, not directly explicitly, but something also I think quite interesting. It's actually based on my research that I have just completed, and it's completely it's different. It's more like a historical ethnographic approach. And in this research, I looked at evolution of society and its interrelationship with power and Buddhism and state ideology. And actually, I conducted 30 interviews, in-depth, semi-structured interviews with community members, with faith leaders, Buddhist leaders, and also some of the experts. And basically the key finding, one of the interesting findings that I observed based on those interviews, was that during this pandemic period, there have been more women. I speak about my region, Buryatia, there have been more women who have attended to Buddhist functions, whether it would be ritualistic forms, like prayers and rituals, or philosophic aspects of Buddhism. So even though there is an age difference, because there are more younger people who are interested in Buddhist philosophy, and there are more senior women, or generally senior age people are more kind of keen on ritualistic forms. But the bottom line is that across the board, regardless of age, there are more women who attend those Buddhist functions. And as I argue in this paper, in this resources, I call it faith-based unpaid care, because women see that attending to Buddhist functions as their responsibility, because obviously during those, whether Buddhist or the philosophic parts or rituals, you kind of the purpose is to look after your family. And I think women have taken more responsibility and stretched even more. And partly because of also state ideology, it's because of this neoliberal welfare and also social norms. So
yes,
it's a little bit different issue, but I think, the issue of faith and faith-based organizations also play a critical role in this conversation.
I think women are often brought in to deal with a crisis, but on the other hand, we do have a lot of women now heading up enormous power in the world, don't we? So there is a reality to the neoliberal feminism that is just able to put care work onto other people so we can get on with our careers and so on. So I think we have to be a bit careful with the complexities of gender, don't we? That it's the job that women have traditionally done, and now it's often not so much mothers and grandmothers, as Daisy said, and others, but there has to be a movement that sort of turns our values around to say, what is life for? Yeah, so I know that some people have turned to Buddhist philosophy. There are Buddhist countries that they certainly wouldn't be turning to. But everything has its contradictions, doesn't it? Unfortunately, but we do have to seize this moment. It seems to me we have now seen what is really important about valuing life itself, and I think there has been in Britain. There's been an increase in mutual aid. There was the caremongering in Canada. I don't know if you've seen anything in Cambridge. Has there been any movements and other things that the rest of you have seen wherever you're based? Would you say there are things that you think are there to build upon? Or it's going to be difficult?
I think for me, in some ways, the solutions are already there. The mutual aid, the massive, solidarity that we're seeing, the sociological review, the caring solidarity, we're seeing, essays of people of what they've been doing, and it's been amazing. So I think the things we need are there. We just need to change the conditions, the structural conditions that they're in. So, but obviously that's the hard
bit. Quite a job. Yes, well, I guess this conference is very much about rethinking how on earth we're going to do that. And I do think that there are many movements attempting to do it. There's just also a lot of other movements, aren't there, that are bringing sort of right-wing populists to the fore. So we just continue, I guess, seeing where we can talk a language of care and a language of kindness, and and say how much that has been devalued. I mean, just the very word kindness itself, that really needs to be brought back. My friend Barbara Taylor wrote with a psychoanalyst a book on kindness. I don't know if you've seen it, arguing that the case for kindness, actually, if you look up Barbara Taylor, you'll see that. And another thing, that if one turns to history, you also see a lot about the complexities of care, and that when the care home, the state care home, was precisely a place where people did not receive adequate care, where, you know, there might have been some hands-on care, but there was no caring about the people in the care homes. You know, they were the ones that everyone knew were not receiving real care. And then, you know, if you think of what's been written on motherhood, particularly anything with any psychoanalytic dimension to it, shows, you know, how much resentment there can be when you're doing something that is undervalued and that, you know, that is required, makes such demands on you full time, and that you can get relations of cruelty and so on in caring relations. So, you know, all that is precisely why we have to have the resources and the infrastructures of care that we're all engaged in. You know, care isn't something that should ever be simply behind closed doors. It has to be out in the open where we can see, you know, this is what a healthy society values. This is what we're here for, it seems to me.
We're going to have to wrap up soon. Are there any final comments you'd like to make?
Yes. Does anyone else want to make a final comment? Or shall I just wish you incredible luck and success with everything you're doing, and to all our listeners who are here to listen to us talking about care. And we've got plenty more panels. We've got a lot more to discuss. We've got Joan Tronto talking to us tomorrow, one of the divas of the care philosophy. So there's a lot more for us to look forward to. It was really great to hear you all. Thank you very much.